Might be a little refresher. Okay, who can define compliance for me? Raise your hand. Don't all do it at once. Nobody remember what compliance is? Or you just don't maybe know how to word it?
Isn't it
Okay.
like agreeing to do something?
Say it again.
Is it agreeing to do something?
So it is. So it's how readily your lung will accept a volume, right? So if you have an increase in compliance, it's pretty easy for it to take in that volume, right? Who's that?
The person or like their
A disease process that has an increase in compliance.
COPD.
COPD, yeah. So that's our COPD patients, right? Their compliance is increased, okay? Their lungs are very pliable. They're easy to take in that volume. And that's just kind of how that is. So if we think about lung compliance and we talk about compliance, it's how easily the lung takes in volume. Okay? So that is compliance. What is elasticity?
Stretching, maybe?
It is stretching, but specifically a way to phrase it.
Like when it goes back, like, you know, when it comes back to.
How easy it is for it to come back down to its original size, okay? So elasticity is how easy the lung returns to original size or shape. So if your lung expands, it's how easy it can actually deflate and come back down to its original shape, okay? So that is our elasticity. Now, do these work, compliance and elasticity, do they work together? Yes. Are they opposing?
They should.
They work together.
They work together, but are they indirectly or directly related, I guess? Indirectly related. They do work together, you're right. So indirectly related. So if I have an increase in compliance, what does that mean? My elasticity is going to be decreased. So what does that mean?
For like COPD patients, they can't get the air out, so their diaphragm isn't going back up to the normal.
Yeah, so that's great. Okay, so if I have a decrease in compliance, right? Increase in compliance, our COPD patients, they can get that air in really easily, right? They are already inflated with some of that volume, so taking in more volume is pretty easy for them to expand, right? But to get that air out is really hard, okay? Because their lungs are lacking that elasticity property, okay? That's kind of what happens with a lot of our disease processes as far as COPD goes. They have an obstructive disorder that has them hyperinflated. So coming back down to that original size doesn't really happen for them. So because remember, they're barrel chested. They have some of that volume trapped in there, so their lungs can't completely deflate like a normal lung can, okay? So our COPD patients have an increase in compliance because they can get that air in, but a decrease in elasticity because they can't get air out, okay? So that's our COPD patients. So then, if I have a decrease in compliance and an increase in elasticity, can I get air in?
No.
No, it's really hard for them to get air in. But boy, they can get air out, right? So that is someone that has a very stiff lung. If you think about it, when you're trying to inflate that balloon right from the get-go, it's very stiff. It's hard to get that air in, and you really have to blow really hard to get that first initial inflation of that balloon. But after you inflate it, it's really easy, okay? But this lung, it's that first initial blow. It's so hard to inflate. So it's like pulmonary fibrosis, right? So a fibrotic lung, ARDS, okay, COVID, all those patients, God bless you, have a very stiff lung, okay? So they're going to be able to get air out because it will come back down. It's so stiff, it wants to deflate, right? It wants to come back down to that original shape. So the elasticity is increased in these patients because they can get that air out because their lung is so stiff, it's just going to collapse and go back down to that original shape very easily. okay? Does that make, yes?
So the first one, the, increased compliance, that one is air, can get air in, but they can't get air out.
Exactly, so a COPD can't get air out. Okay, and then this one is going to be fibrosis or fibrotic lung. Okay, or stiff lung, however you want to say that, can't get air in. And fibrotic lung can be pulmonary fibrosis. It can be ARDS, COVID, all those patients. Very stiff lungs, okay? So it's hard to ventilate those patients, right? We'll talk about that once we start talking about our ventilator, but it's gonna take a lot of pressure to just get a little bit of volume in these patients, right? So what are we worried about when putting a bunch of pressure into a lung? Collapse from what? If we're pushing a lot of pressure in, what do you think?
Overexpand.
To a very stiff lung, it might pop, right? We might get a pneumothorax.
Yeah.
So barotrauma, okay? I don't know if we've talked about that before. So we'll get into all that fun stuff. But those are the things you're gonna start talking about next year. But anywho, okay, moving on. Define airway resistance. What is raw? What is raw, right? Say, what's that?
Work of breathing.
Yeah, it definitely causes an increased work of breathing. So you're having some kind of impedance or resist, something's causing the air to not get through the airway easily, okay? So it can be anything. It can be secretions, it can be inflammation, anything that's causing, it can be a tumor in the airway, something that's impeding airflow, okay? So impedance of airflow or a flow through airway. And that can be from a lot of different things, okay? Impedance of flow through the airway is going to be airway resistance. And that increases the work of breathing, right? If you can't get air through your airway, you're definitely gonna try to breathe faster, or you're going to have that increased accessory muscle usage because you're trying to overcome that resistance so you can get that air in. Does that make sense?
So sorry.
You gonna wipe something out?
You know, I decided not to see eraser pens.
Yeah. Oh no. I do it. Okay. Does everyone understand airway resistance? Raw. Okay. What is surface tension? I remember we talked about this. What is surface tension? So this is, so surface tension, if you said, I know, you're like, oh. So when we talk about our alveoli, where does surface tension lie? Right on the outside, right? So where the alveolar, like membrane or tissue, and our surfactant kind of come together, right? Mm-hmm. So there's that surface tension. So surface tension is the pressure that is going to be exerted, and it usually says bubble, but on our alveoli, that can cause collapsing, right? So it's just the overall pressure that's being exerted in that, again, it says bubble, but in that alveoli, okay? So that's just the surface tension. That's the amount of pressure being exerted inside the alveoli, okay? Now, when we talk about surfactant, it helps to decrease that surface tension so we don't have that collapsing of the alveoli, right? So we never want a lot of surface tension in our alveoli, or they'll collapse, and then what do we have? Atelectasis, okay? So surface tension is the pressure that's being exerted inside of our alveoli, okay? And it's going internal, so it's going inside and it's wanting to take that tissue and collapse and make it collapse. But our surfactant helps to decrease that surface tension so they don't collapse. Is everybody here with me?
Mhm.
We're gonna go through it again, but I just wanna make sure everyone's a little bit on board.
Pressure being exerted on the alveoli internally.
Okay. All right. We're gonna do this. Okay. Work of breathing. So everyone kind of has their own way of, I guess, every type of patient. So we have our elderly, our adult patients, our peds patients, our infant here. Different ways of telling that a patient is having an increased work of breathing, right? So what are some things we're looking for in our adult patients?
Their
Use of accessory
Yeah.
muscle.
Accessory muscle usage, tripoding. What do they do with their lips usually? First lip breathing, right? Cyanosis. So nasal flares is where? Where are we seeing?
Babies.
Babies, yes. So our infants, very good. We see nasal flaring because they are
Their nose breathers.
obligate nose
Mouth,
breathers. There you
yeah.
go. Obligate, and they're babies, yeah. They're obligate nose breathers, which means they primarily breathe through their nose, okay? Because remember, they're usually eating. So that's kind of why their body works that way. So in our infants, we're gonna see nasal flaring. What do we call this right here? And it's hard to see. Retractions, okay? We're looking for that substernal retractions or within the ribs, okay? Intercostal retractions. So those are things that we need to identify for our patients to make sure that we understand what increased work of breathing looks like, right? So, remember, talking about compliance and elasticity, this is kind of a summary. Loss of elastic lung tissue results in increased compliance. Okay, so if you don't have that nice tight elastic, what's going to happen to our lungs? It's going to be kind of floppy. It's not going to be nice and tight down like it should be. So it's going to kind of be a little bit expanded and easily stretched, right? It's going to be stretched out. Okay, so that's what's happening. We've lost that elastic property within our lungs, so it's no longer nice and tight and not overly stretched, if that makes sense. Okay, so example of increased compliance is COPD. So especially like our emphysema, right? That is a real big one that we will notice has a decrease in that elastic property, okay? So COPD, they cannot get air out, right? They can get air in, but they can't get it out. So if we have an increase in elasticity, it's going to, of course, result in a decrease in compliance, okay? So if we have an increase in elasticity, it means that we have a lot of stiffness, okay? I don't want you to think about, oh, it's just super stretchy. That's not what it is. It's the elastic recoil, okay? So to that lung to come back down to its original shape. Okay, so what's going to happen is we are going to have a decrease in compliance. So does that mean that this patient is going to be able to take in a huge tidal volume really easy?
No.
No, it's going to take a lot of effort to get a little bit of volume. Okay, so they can't get air in. Okay, what's an example of this? ARDS, fibrotic lung, so pulmonary fibrosis, COVID, okay? Anything that's gonna cause that lung to not be able to stretch to its ability, right? Take in that volume. Okay. Surface tension. The cohesive force of at the liquid gas interface. Okay. So that's just that pressure that we were talking about, right? So inside of any sphere, bubble, alveoli, there is this force, okay, between the liquid, which is our surfactant, and then the gas, which is the oxygen and the nitrogen and all those fun things that are in our alveoli. So what those two meet is surface tension. So if we have a decrease in that liquid, it's going to cause, which our surfactant, it's going to cause that surface tension to increase. Okay, and when we have an increased amount of surface tension, sounds like it'd be a good thing, right? Give me all the surface tension, but it's bad, especially when in our alveoli. If we have an increased amount of surface tension, that is going to make our alveoli more readily able to collapse, okay? So the more surface tension you have, the more pressure that's exerting in on that alveoli and making it want to collapse instead of staying open, okay? So our surfactant decreases that surface tension, allowing the alveoli to stay open, okay? Does that make sense? A little bit? So the higher the surface tension, the more likely our alveoli are going to collapse, okay? So that's why we talk about, and when we talk about atelectasis, we're talking about usually like some kind of washout of that that surfactant, right? Something has caused that surfactant to either decrease or something, yeah, causing that, maybe there's a compression from the outside source, okay? Causing that surface tension to increase and that collapse to occur. So the surface tension helps maintain the shape of water droplets or makes it possible for insects to move or stay afloat on the surface of a pond. So that is ultimately surface tension. But when we're talking about in our lung, it's that pressure exerted inside that alveoli. Okay, so when we talk about surface tension, we can't not talk about the law of Laplace. Have you guys talked about this a little bit with Dr. Prager yet? No. Love to hear that. Okay, so what is the law of Laplace? So it's talking about different pressures and how they are indirectly and directly proportionate to each other, okay? So its distending pressure of a liquid sphere is directly proportional to the surface tension of the liquid, okay? So when I talk about distending pressure, it's the pressure that is needed to inflate that alveoli, to distend the alveoli, okay, and open them up. So it's saying that the pressure is directly related to the surface tension in the liquid. That makes sense, right? So if I have an increase in its surface tension, which is going to mean that my alveoli want to collapse, I'm going to need a lot of pressure to keep that alveoli open, right? Because I have to overcome that surface tension in the alveoli. So that makes sense, right? So it's saying that distending pressure is directly related to the surface tension. Okay? So if surface tension goes up, so does our distending pressure, our driving pressure. Okay? So it's inversely, which means that they go in the opposite direction, right? Proportional to the radius of the sphere. So what is the radius? Anybody know? Yeah, so like if we took our radius, it would be like this, right? That'd be our radius. So it's saying how big, pretty much, that alveoli is, okay? So it's saying that the distending pressure is inversely proportional to the radius of the sphere. Okay, so if the sphere is larger, it's saying that I don't need as much distending pressure to open it. Okay, if the sphere or alveoli is smaller, it's saying I'm going to need a lot of pressure to keep that open. Because what actually is happening is the smaller the sphere, the more surface tension there is inside of it. Okay? There's more surface tension in those smaller alveoli than those larger ones. So that's why it's going to take more pressure to keep those small ones open than the bigger ones. Okay? So when we have two alveoli and they have the same surface tension, so if we had two alveoli, that's kind of what this one is saying. If we have two alveoli and they have the same surface tension, as far as like a small and a large one, the smaller one is always going to just collapse into the bigger one because the surface tension is higher in that one versus, or it's more likely it's going to collapse because it's smaller than the larger one. So it just collapses and goes into the larger one.
Which is that hypoxic where it diverts?
Well, that was talking about perfusion, so you're not the same thing, but it's okay. So not a big deal. But that's typically what happens: is the smaller one always collapses and goes into the larger alveoli. okay? Because it's going to take more pressure to keep that smaller one open than it does the larger one, even though they have the same amount of surface tension, okay? I know that's kind of a hard concept, but that's what the law of Laplace is kind of saying, okay?
I thought you just said though that the smaller alveoli has higher surface tension though.
It typically does. I'm saying if they were exactly the same.
If they're the same size.
And they can be the same size. No, it'd be the smaller one and the larger one. It'd just be that the surface tension for some reason is the same. Then the smaller one is going to collapse into the larger one.
If the surface tension is the same in
Mhm.
both.
Especially if we didn't have any surfactant.
But typically the smaller one surface area is supposed to be higher.
It is, yes.
Okay.
So don't stress about that. It's not, I don't want you guys to cause any confusion. But typically in general, if we have two alveoli next to each other, one's smaller and one's larger, the smaller is always gonna try to just collapse into the larger one. It's just easier for our lungs to ventilate those bigger alveoli, okay? Especially if we have some kind of surfactant deficiency or something's caused a washout of surfactant. Okay, so what I want you to know about law of Laplace is right here. The descending pressure is directly proportionate to the surface tension, and it's inversely proportional to the radius, okay? Okay,
So focus more on that than what you just said about the
Yes.
collapse, okay?
yep, yep. Okay, surfactant, so now we're talking about surfactant. Surfactant weakens is the first blank. Surfactant weakens the molecular bonds at the surface, reducing the surface tension and decreasing intra-bubble pressure. So decreasing is the next blank. So let's read it again now that you guys have it written, okay? Surfactant decreases, or weakens, the molecular bonds at the surface. So when we're talking about the molecular bonds, we're talking about at that liquid gas surface, liquid gas interface, okay? So that surfactant is going to weaken that molecular bond, okay? And that ultimately decreases the surface tension and pressure inside of that alveoli, okay? So that's what surfactant's doing. So that's going to help keep that alveoli open, right? Decreasing surface tension, ultimately, good thing, right? Okay. Number 2, pulmonary surfactant exists as a single molecule, thick film lining the alveolar walls, okay? So it's that thick, we already know all that. It's that thick lining, thick film that lines the alveolar walls. Surfactant's ability to decrease is the first blank there. Surface tension depends on a ratio between surface tension and alveolar surface area. We already know that. We just literally said that a little bit, right? Surfactant's ability to decrease surface tension is going to depend on the ratio between how much surface tension we have in our surface area. Surface area can be our radius, right?
Mm-hmm.
So that's kind of what we're talking about. So it really depends on that surface tension and the radius. So during inhalation, alveolar surface area increases because our alveoli distend, right? Surfactant film becomes stretched, causing increased surface tension. Okay.
The first one was increases, right?
Mm-hmm.
Yes. Increases and then increased. Okay, so let's think about this. During inhalation, the surface area, so that radius, increases, right? That makes sense. We take a breath in, our alveoli come a little bit more distended, right? So it stretches, and it stretches out that surfactant, okay?
Mm-hmm.
And so now the surfactant is a little weakened, right? It's a little weakened, and it causes an increase in that surface tension, okay? Why would we want that? Because it helps with passive exhalation. okay? So that's normal. This is our body's way of making it easier for us to exhale and get that air out. So it's not that they're going to completely collapse, but it is going to say, okay, now I'm distended, you need to go back to your normal shape, okay? And it helps with that passive exhalation and getting some of that volume out, okay? So that's what ultimately what's going on during inhalation in our alveoli, okay? And that's why that takes place and what the purpose it serves, I guess. Okay, moving on.
So alveoli kind of have elasticity, like the lungs, essentially.
Yes, they're all the same. The tissue on alveoli, it would all be, that's where a lot of that elasticity starts to decrease. Because remember, like we think about emphysema, and what actually happens in emphysema is the destruction of those alveolar walls, and that's what's causing that elasticity to not be there. It's actually breaking down that elastic component in the lung, in the alveoli, okay? So that's, yes, absolutely.
Okay.
Yes. Okay. Good question. All right. Let's think back. Man, we gotta think back. Okay. So what are the 4 beneficial effects of surfactant?
Keep
Keep it
alveoli.
dry.
Jordan, you raised your hand. Love it.
Decrease work of breathing.
Decrease work of breathing. Absolutely. All right, Whitney, girl, what is it?
Keep the alveoli open.
Yes. So it keeps the alveoli open. I got you, Sean. I just want to make sure everyone's got it all. I don't want to stress anybody out. Okay, what's your next one?
Does it keep it dry?
Yes, so it keeps the alveoli dry. Is there anybody else besides Whitney, or I can just call him Whitney again? Can't be Jordan. Nobody? All right, Whitney.
Surface tension.
Yeah, decreases surface tension. Absolutely. So decreases surface tension, decreases work of breathing, prevents alveoli from collapsing or keeps them open, and then keeps them dry. You'll have to forever know those. I would just star it. You're gonna know it. You're gonna need to know it. Okay, so there are several causes of decreased surface, decreased surfactant, I'm sorry. So, does anybody have their book? I know I don't
It's
know.
122.
This is 122, so it's that A&P book.
Yeah. This one.
Yep, cardiopulmonary.
Which page do you think it is?
It
Oh,
is
wait.
on page 114, at least it should be. Check to see if I'm updating my page numbers. Yes, right here. So it's the surfactant,
Oh, the top chart.
page 114, yes. So it says see table 2-1, is that 2-1?
Yeah.
Okay, good. All right, so what are some causes of decreased surfactant? Sean, go ahead, lay it on me.
Acidosis.
Acidosis. Okay, what else?
Do you want somebody else to answer, or you just want me to tell you?
It doesn't, I got 2 people with a book, maybe, but go ahead. Acidosis,
Hypoxia.
hypoxia,
Hyperoxia.
hyperoxia,
Atelectasis.
atelectasis,
And pulmonary vascular congestion.
pulmonary vasculature,
Congestion.
does it have a lot more?
No, oh, it says specific causes. Do you want those?
So just go ahead and list a few of them.
ARDS.
ARDS. So these are the disease processes that we're talking about. ARDS,
Pulmonary edema.
edema.
It has RDS, but I figured that's probably the same as ARDS.
It's just for infants, yeah, RDS.
All
right.
Pulmonary embolism.
PE,
Pneumonia. It says excessive pulmonary lavage or hydration.
oh, okay. So like a washout on accident. Oopsie. All right.
Near drowning
Near drowning.
and extracorporeal oxygenation.
Extracorporeal of 2. That is ECMO. Okay. So, let's think about this. ARDS. We have a decreased amount of surfactant. So, does that make sense with our compliance issue? Because does it have a decrease or an increased amount of compliance?
I'm sorry, what did you say?
ARDS, was that our increased or decreased compliance? Decreased compliance. It has a decrease in surfactant. That makes a lot of sense, right? Okay, pulmonary edema. If you have fluid in the alveoli, is your surfactant going to be working sufficiently? No, okay. PE, that's going to cause pulmonary hypoxic vasoconstriction, right? So we're gonna have a whole nother issue as far as that goes. Pneumonia, again, we're having a decrease in compliance, near drowning fluid, and as far as ECMO goes, it depends on what kind of ECMO, but I'm assuming it's talking about the VA, VV, doesn't matter, I guess. VA, VV, you're not typically ventilating your lungs as well because you don't need to. It's actually happening outside of the body. So you don't need to typically have a lot of that ventilation, so. Okay. What are some signs and symptoms of decreased surfactant? So decreased surfactant, what happens to our alveoli? You did it.
Dry.
They collapse, right? So what is that called? Atelectasis. So that might be a kind of a sign, right? What comes with atelectasis? What type of breathing are we gonna see? Increased work of breathing. So increased work of breathing. What else do you think? What happens when you have atelectasis and increased work of breathing?
Fever? Also, some say fever.
Fever comes with atelectasis,
Right.
correct? Yes, absolutely. Breath sounds, I can identify atelectasis that way, but definitely fever. What happens to our oxygen, you think? Is it gonna go up or down? Down. SpO2 is gonna decrease for sure. What happens to our lung compliance if we have a decrease in surfactant? Is it gonna go up or down? Down. Decreasing compliance, for sure. It's gonna take a lot of pressure to get those alveoli open. And what will we see with our babies?
Nasal flaring.
Nasal flaring. They might grunt with each breath. You'll see that's kind of another sign of their increased work of breathing.
I'm gonna be so sad working with babies.
It's not an easy one. Not an easy one. Okay. So surfactant definitely leads to a lot of different things, or decrease in surfactant, I guess, ultimately. Okay, we're moving on to raw airway resistance. Resistance that results from the movement of molecules of inspired gas over the surface of the airway. Makes so much sense, right? I mean, it sounds good. Ultimately, it's the difference between the mouth, the pressure in the mouth, and the pressure in the alveoli. So that's what the equation is. So if you're gonna technically do the equation to get your raw, right, you have to have your change in pressure, which is what this little caret means. Change in pressure over flow, which is what the little V and the dot means. Okay, so raw is the change in pressure over flow. You guys will be doing this on your patient assessments eventually, okay? So when we're looking at it, we're looking at the change in pressure to see if we have a different pressure at our in our airway to our alveoli, okay? Because if we do, then we know there's some type of obstruction, right? Okay. So raw. When we're talking about lumen size, we're talking about typically the airway, okay? So do you think, when we're looking at airways, do you think that this is going to have impede flow, having a smaller lumen?
Yes.
Absolutely. So it's going to impede flow and it's going to ultimately increase airway resistance, right? So the smaller the lumen, so raw increases when the lumen size decreases.
Oh,
Yeah. So raw increases when the airway or lumen size decreases. Because air is meeting resistance, okay? It's meeting resistance just from the walls of the airway, okay? Does that make sense? Okay. So if I actually decrease my radius by just half, cut it in half, it increases the flow, decreases the flow to 1/16. That's crazy. That's a lot of flow impedance, okay? Just by decreasing our airway in half, okay? That's huge. Okay, 60% or more of raw is from the nose, pharynx, and larynx. Just a fun fact for you there. I mean, if you think about it, how many, we have our turbinates, like all of that, anything that it's hitting on the side, that is considered to be some kind of a resistance. And you think about all of the surface area in your nose, and then it has to go down the back of your throat, it's hitting the back of your throat. So, a lot of raw is happening up there regardless. But we don't want any raw in our lungs, right? That's where we want to really make sure we don't have a lot of that impedance.
Can you say that 1/16 thing again?
So you decrease the radius by, decrease radius, I'm just going to put R in half, decreases flow, airflow, did I say airflow? Yeah, just flow to 1/16. So a decrease in radius by 1/2 decreases the flow to 1/16. All right, number 3, raw blank as gas goes into the smaller airways due to cross-sectional area blank greatly. Okay, so we're going into small airways. What do you think is going to happen to raw? Is it going to go up or down going into smaller airways? Going to go up, right? The smaller the airway, that means we're decreasing our lumen size. So raw is going to increase as it goes into some of those smaller airways, okay? So raw increases as gas goes into smaller airways due to cross-sectional area increasing greatly. So you have more of those cross-sectional areas in smaller airways. So what does this mean? This means that someone can have a disease process in their smaller airway and you won't even know it for a period of time, okay? It won't show abnormalities until someone does a PFT. They call it the silent zone as far as being down in that lower area. So typically, because the raw is not up in the larger areas, it isn't making as big of a difference in that work of breathing, okay? It's in those smaller areas, so it's not causing the patient to show these signs and symptoms until it's progressed to where it's now impacting more of those larger airways. Does that make sense? So that means that if they aren't going to the doctor to get a PFT, or they're not having any clinical signs and symptoms, then they're going to be living with this and having this increased raw in these lower areas of their lung without knowing it, okay? Until it gets worse to where they now maybe have to be on, who knows, it could be that they need to have a BiPAP, CPAP, might need some assistance in that way, okay? So, normal raw, it's in red. I feel like we need to know that. For non-intubated patients, I want you to know that. So these patients are not intubated because that does change once we have an intubated patient, okay? We accept a higher amount of raw because of that endotracheal tube, okay? But For our non-intubated patients, a normal is 0.6 to 2.4. 0.6 to 2.4 centimeters of water pressure per liter per second. Okay. Did I skip a page or no? No, good, okay. Poiseuille's law. This is yours, yours looks the same. I haven't printed off an updated one of mine, that's fine. Okay. Have you guys talked about, so Poiseuille has a few laws, right? Have you guys talked about Poiseuille's law at all? No? Okay. So it's law and we're talking about pressure and flow. Okay, so we're going to talk about how these two are related. So, flow. For flow to increase in an airway with no change in radius, meaning our lumen size is the same, okay, so for flow to change without that lumen size change, there has to be an increase in driving pressure, okay? So what they're saying is for me to increase the amount of flow or decrease flow, I'm gonna change the pressure, the driving pressure at which I'm providing that flow, if there's no change in the lumen. That makes sense, okay? So if our patient's on a CPAP of 5, I'm providing a pressure of 5 to those lungs, right? If I wanna increase flow, I would have to increase my pressure to a CPAP of 7, right?
Mm-hmm.
Or if I wanted to decrease flow, I would decrease it to 4. Okay, that's all that that's saying. No change in the lung airway size, the radius is the same. So if I need to change the flow and there's no change in radius, then I just need to change my driving pressure. Okay. So, thus making flow and driving pressure directly related. Okay. So to increase flow, you need to increase driving pressure. Okay. All right, all right. So now, so that's our flow piece of this. If we are now looking at our pressure, if pressure is constant and there is a decrease in radius, the flow will also decrease. Okay, that makes sense, right? So if we have a decrease in if our airway was this big and now it's this big, did we lose flow? Did we decrease flow? The amount of flow in that airway? Yeah, right? I mean, we're not talking about raw, that's a whole nother situation, but we have now decreased the amount of flow, okay? So if pressure decreases, if there is, if pressure is constant and the radius decreases, the flow is also going to decrease. So what does that mean? So a decrease in radius means a decrease in flow. So are they directly related?
No.
Yeah. So if there's a decrease in radius, there's going to be a decrease in flow.
Bernoulli's principle contra, or
That's a different law.
okay. This is
Poiseuille's.
sorry.
That's okay. Does everyone get that? Okay. So, making driving pressure and radius directly related. Okay? So, if there is, I feel like that's not right. I should say making radius and flow directly related. I think that's what I meant to say there. But if you decrease pressure, you also decrease flow. So I guess it doesn't, that's fine too.
So are the laws situational? I'm confused.
You mean like why you would have a smaller radius versus a normal size radius?
No, I'm just thinking Bernoulli's principle on this one is confusing me because increase in radius or decrease in radius would increase the flow for Bernoulli's, and then for this one, like how would we know which one to apply?
This isn't Bernoulli's.
I know, but I'm just asking like which law would we apply in which situation, you know?
Well, we're gonna ask you about, like I'll say like the law of Laplace.
Oh, okay.
Yeah. So don't try to intermix them. I know it's hard. There's a lot of laws. Don't try to intermix them because they're already hard on their own. Okay, so a decrease in pressure is going to also decrease flow. So driving pressure and flow are also, I think we already said that, is directly related. So a decrease in radius and a decrease in flow, and then decrease in radius, increase. Okay, I already covered all the ones. I just want to make sure I'm covering all the things I have here. Okay, any questions about this one? You guys feel pretty good? Makes sense? Okay, so we're going to talk about some thought questions about raw. So list a disease and or condition causing increased airway resistance. So we already talked about this a little bit. What would cause an increase in raw? Yes.
Tumors?
Tumors. Tumors, absolutely. Did you say COPD? Yeah, COPD would also, because you have some type of airway obstruction, right? So that airway obstruction is going to cause an increase in airway resistance, right? It's obstructing the airway. Okay, what else? Secretions, yes. So pneumonia would be a good example, yes. What about atelectasis?
Yeah.
Yeah. Okay, list the physical findings a patient with increased raw would exhibit. How would they look?
Increased work, so they'd have nasal flaring.
Yeah, nasal, tripoding, increased work of breathing, right? Ultimately, yeah, potentially cyanosis. What comes with cyanosis? Or what's gonna happen to our SpO2?
That's gonna decrease.
It's gonna drop, right? What also can happen with raw? If we have narrowing of the airway, what breath sounds might we hear? Some wheezing, right? Potentially some wheezing. Okay. Discuss therapeutic options for patients with increased airway resistance. Okay, so we have to find the underlying issue, right, to fix our raw. So if our raw is that we have narrowing, narrowed airway from asthma, how could we help that patient? Bronchodilator, right? Okay. What about a tumor? Take it out. Yeah. So yes. So maybe a tumor resection. Okay. That would be an option. Not for us, obviously, but you know what I'm saying.
Let me get in there.
Yeah, I'll take care of it. What about secretions? Okay. Yeah. Suction. You can eucalyptic would help thin it out. You're not wrong there. But suction. What about atelectasis? IPV or IS? Lung expansion in general. Lung expansion, right?
Bronchial hygiene, I guess.
Well,
And
so
they
it
did
depends on if
IPV,
it's secretions, yes.
Did what kind, I guess.
Mm-hmm. Yep. Very good, you guys. Okay. So now we're going to talk about gas flow patterns. So the first one we have up there looks beautiful. It's laminar. Everything looks great. Okay. So when I say laminar, it means it's parallel to the tube or the airway. Parallel to the airway or tube. And this is pretty much how we are classifying movement of air through our airway, right? So they can be termed these three things. So it can be laminar. Do you think that we're going to have a lot of raw with laminar?
No.
No, it looks pretty good, right? Yeah. Okay, turbulent, on the other hand, kind of looks like it's random all over the place. We call it random manner of airflow. What do you think? Are we going to have an increased amount of raw?
Yes.
Yeah. And then the third one is tracheobronchial or transitional flow. So we have kind of a combination. So we have both laminar and turbulent. So usually this is kind of where we have that branching out, where we have some laminar coming in and then it's hitting some kind of, like the carina or some kind of branching to a new airway. And that's usually where we have a combination of them, okay?
You said turbulent is just random flow?
Yeah, random manner of flow pattern is really what we're describing.
Is that last one normal? Does that normally happen?
Yeah, so in that instance where it's at a branching, that can be normal, absolutely. Mm-hmm. Yep.
So raw, would it be increased for the third one?
It would in the turbulent areas. Mm-hmm. Okay. Checkpoint. Compliance, remember, definition. How easily air can go into the lung, right? How easily the lung can expand, given any volume. So our normal compliance on a non-intubated patient is going to be greater than 60 is our static compliance that we look at usually, but in dynamic, which we'll talk about this at a different time, is 30 to 40. So there's dynamic static compliance and there's static compliance. You will not be tested on that, so don't stress about it.
So don't even write that at the moment.
If you don't want to write it down, don't write it down. You'll have to know it one day. Okay, so what causes an increase in compliance? What disease process? COPD. Emphysema. And what causes a decrease? Yeah, so pulmonary fibrosis, ARDS, atelectasis, those are all going to be decreased compliance. And airway resistance, you can say the definition is your change in pressure over flow. So that, remember, it was, you can change of, this means change of pressure over flow. Okay? And what was our normal for a non-intubated patient? 0.6 to 2.6? Yes, you're so right. 0.6 to 2.6 centimeters of water pressure per liter per second. And what causes an increase in raw? Tumor secretions, right? How do we decrease raw? Say it again. Yeah, fix the issue. So determine what the underlying issue is that's causing our raw and fix it, right? Because it depends on what's causing it. Ultimately.
What was the normal value for compliance?
Greater than 60 for a non, so there's static and there's dynamic. Static is lung and chest wall. Again, you guys, we're looking down the road. And then C-dyne or dynamic is going to be 30 to 40. And these two together make up lung compliance. Can't wait, right? More equations. They never.
Did you say we don't really need to know these?
Correct.
At the moment.
At the moment. Okay, test your knowledge. Pulmonary disorders that decrease a patient's lung compliance and hinder chest expansion include all the following except. So, we're saying which one of these does not decrease a lung compliance? Who does not have a decreased lung compliance? Sean.
Activity.
Yeah, emphysema, right? So this has an increased lung compliance. That's our COPD. So all of these A, B, C, they have a decreased lung compliance, and this is that except question. So it's saying all of these have decreased compliance except for emphysema. Okay, this next one's gonna be a doozy. When arranged for flow, Poiseuille's law states that flow is, God bless you, B, it's directly proportional to pressure and directly to the radius. So remember, Poiseille, if you have a decrease in radius, what's gonna happen to our driving pressure? It's gonna go down too, right? Our pressure ultimately is going down. So whatever the pressure is doing, the rate and the radius, they're gonna be together. Decreased radius, decreased flow, decreased pressure, decreased flow. Okay. The gas flow that would be found when flows are high and pressures are high would be when? So think about it. If we have high pressures and high flow, gas flow,
Is it turbulent?
turbulent, D.
There's no raw for women.
Say it again.
I was
Yeah, the
saying
pressure,
you-
yes,
yeah.
yep. All of the following functions of, these are all the following functions of surfactant except
C.
C, increasing surface tension. It decreases surface tension, right?